Dullness. The most reliable clinical sign to detect is checking for bilateral flank dullness. If a patient with ascites is lying supine, fluid accumulates in the flank regions, leading to dullness on percussion. At the same time, the air-filled bowel loops are forced upwards by the free fluid due to buoyancy, resulting in tympanitic percussion. To locate specifically where dullness shifts to tympany or the air fluid level, percussion should be performed from the sides towards the middle. To confirm that the dullness is caused by ascites, ask the patient to switch to a lateral decubitus position. If ascites is present, the air-filled bowel loops will shift accordingly and remain at the surface of the fluid. As a result, the air fluid level will shift as well. This is known as shifting dullness.
It's normal. So do you think as a nurse you'll do this as often? Probably not, but you may see the provider doing this to assess for. Paracentesis. So the goal with that one to help relieve respiratory distress. So as we build up fluid in the abdomen, okay, that's going to create pressure on what? That helps us breathe. The diaphragm, right? So we're not going to be able to have that good lung expansion, okay, because of the pressure. So we do this when diuretics are not effective because diuretics can help to hold fluid, right? But if that's not effective, we may need to move to a paracentesis. Has anyone gotten the opportunity to see a paracentesis? Okay. So the diuretics that we may use is spironolactone. Okay. It's our first choice due to the increased aldosterone. So I touched on that, but we'll talk about it more. Okay. And then we also will use furosemide, so Lasix, right? So some patients, okay, with paracentesis, okay, we want to pull the fluid off pretty slowly. I say that, but then you're going to see these providers take off liters upon liters of fluid, right? But we don't want to cause an extreme fluid shift, okay? Why do you think with a paracentesis our bladder should be empty? Our bladder's distended. What happens if you hook that bladder? Right, we're gonna get some urine that fills up our collection canisters instead of our abdominal, our paracentesis materials, right? So make sure the bladder's empty. Okay, we talk about that in 2032 with C-sections. Okay, when you go to the spring semester, because we don't want to do a C-section and cut open someone's bladder. Okay, we need to, before any type of abdominal procedures, empty the bladder. Okay, very important. You may see them administer albumin to maintain intravascular volume because again, we don't want to cause any fluid shifting because what does our fluid follow? Volumes, right? So we don't want to cause any fluid shift by removing a large amount of fluid. Okay, everyone following? Okay. Good. There is a link in the module for a full paracentesis procedure if you have not seen one. Okay. Did Mrs. P cover thoracentesis? Yeah. So know the differences too, right? So thoracentesis, you're going to pull up a lot less fluid than typically your paracentesis, right? So understanding the differences between those. Okay. Esophageal varices. Okay. So esophageal varices are a direct complication of your portal hypertension. Okay. If the varices have thin walls, okay, you may see esophageal varices rupture. Has anyone ever seen that? Okay.
Copious blood.
Copious blood, right? My patient, it wasn't my patient, but the patient I witnessed, very new nurse, baby nurse on 2 West, and I saw this patient and they were vomiting up so much blood that it filled their patient tray bowl, those blue things that keep the food warm, right? Just piles upon piles of blood, and it started to clot, and he was gone before the cocaine even run. Okay, that quickly, okay, because the pressure of the blood coming through that portal system and into those varices is a lot, and you bleed out very quickly if this happens, okay? If you have rectal varices, okay, that GI bleed could happen very quickly. Okay. Has anyone heard of vaping causing esophageal varices now? Okay. I saw one of my friends, they had a family member who was vaping, and they didn't know they had esophageal varices, and they went to cough and they started spewing blood. They didn't pass away because they weren't as severe varices or they weren't as thin walled, but their whole bathroom just looked like same scene, right? So very dangerous. That's what I want you to take from this, right? Massive hemorrhage. Okay. Complicated by impaired clotting factors. So again, somebody vaping, they probably don't have impaired clotting factors, right? However, does someone with cirrhosis end up with impaired clotting factors? Yes. Okay. So how are we going to treat this? If we're able to treat it, we're going to give vitamin K to help clot. Packed red blood cells, probably a massive transfusion protocol, and fresh frozen plasma, so hopefully they stop bleeding. Okay. Then we're gonna have to fix it, right? So they may do endoscopic sclerosis, which is like an injection form to help with the bleeding. Band ligation, if there's a specific part of a varice that's bleeding, they can ligate that or close it off. TIPS procedure and shunting the blood away, okay? Or balloon tamponade. Okay, I'm gonna hopefully show you a video of that. Let me see. Yes, Blakemore tube.
Mark has just
So if
Granger's got it.
patient that I observed having esophageal bleed, if they were able to stabilize this patient, you know, when the protein got there, I mean, in minutes, they probably would have done something like this to try to help. Okay.
Here is the ever so simple Minnesota tube. In addition to the tube, you are also going to need 2 3-way stopcocks, 4 dual lure lock caps, a Christmas tree, a Kelly clamp with tape around the edges so you don't cut your tube. Now you need a manometer. I recommend the Posey cuff later. Respiratory has them. Call RT, you need that item. A 50cc syringe, a marking pen, lubricating jelly, and a traction device. We're going to use Curlex and a 1 liter bag of saline, and you also need a bucket of water. There are 2 balloons, one for the esophagus, one for the stomach. There are suction holes here for the stomach and suction holes here for the esophagus. There are 6 ports. I know it's a little confusing and only 4 are useful. Let's go through them. There's one here for suctioning out the stomach, and there's one looks just like it for suctioning the esophagus. There is a port here for inflating the esophagus balloon. And then there's this thing. Leave that cap in. That's meant to be a manometry port, but it's useless. And this one is for inflating the stomach balloon. Again, leave that cap in place. The manometer is supposed to fit there, but it doesn't. But it does fit on a 3-way stopcock. You'll see. Now we're going to place our 3-way stopcocks in the stomach balloon port, and then one in the esophagus balloon port. And these fit pretty snugly. They seem to be airtight, so it's good just as it is. Now I'm going to check my balloons for leaks, and I'm going to start with the esophagus balloon. But this is your opportunity to really be creative. Choose whichever balloon you want to check first. I'm going to dunk it in some water and inflate air, just like you would with a bicycle tire, and look for bubbles. That one's good to go. Now you want to make sure you fully deflate all the air from the balloon. Now I'm going to check my stomach balloon, and I want you to remember that once you've completed this portion of the procedure, the easiest part is over. So use the same technique, put it in some water, inject some air, and boom, no bubbles. We're good to go. Suck all the air out of the stomach balloon so it's nice and flat. Now you're going to lubricate your tube and your balloons, and you want to use a water-based lubrication so it doesn't damage the tube. And when we insert it, it's going to be just like an OG tube. You technically can go through the nose.
You know, the first time I watched this video, I thought to myself, if I was ever a DNR and I had special, you know, things I didn't want done to me, I'd probably say not only no intubation, but no tubes, people. I don't want this, right?
but I think it's easier to go through the mouth. Now you want to insert the tube all the way, and then we're going to check to confirm that it is in the stomach, not the esophagus. So you're going to inject 50 cc's of air into the stomach balloon. This is not your opportunity to be creative. You have to start with the stomach balloon. So inject your 50 cc's of air, and you're going to get an x-ray and confirm that it is below the diaphragm. And now it is safe to continue. Now you're going to fully inflate the balloon, and with the Minnesota gastric balloon, it holds 500 cc's of air. That's 500 cc's of air, which is 9 more pushes from your 50 cc syringe. Now you can close it off and place your cap so you don't get any air leaking out of that balloon that you worked so hard to get in the right spot. Time to set up traction. Now go get that football helmet and throw it in the trash, because we're going to do this with some Curlix and a liter bag of saline. That way nothing's blocking your airway. Make a slip knot with your Curlix around the tube and secure it down. And with the other end, grab your liter bag of saline, and you're going to pull those ends through the hole in the top of the bag. Now you're going to tie a knot here, but this is an opportunity for creativity. Any type of knot will do. Now you can hang this up over your IV pole, and it's going to give you 1 kilogram of traction on your tube. Now stick with me, we're almost there. It's the top of the 9th. We're going to hook up suction to our gastric aspiration port and suction out the stomach. And once that's all done, you're going to clamp this port using the Kelly clamp with fancy tape. Remove the suction from the gastric port, and now the search is on for the esophagus port. Connect your suction here, and if you have persistent bleeding in the esophagus, now you need to inflate the esophageal balloon. Grab your manometer, and it connects pretty nicely here into the stopcock. When you squeeze the bottom of the cuff later, it inflates the esophagus balloon, and the goal is 30 millimeters of mercury. You can go up to 45 millimeters of mercury if you need to, but let's stop here and check to see if we have tamponade. Turn the stopcock to off and replace the caps on the end of the stopcock. And just like the Linton tube video, mark with the pen at the lips so you know if the tube is pulling out. And there you go. That is pretty much what it looks like, except with a lot more blood.
Can I just say, that's what real nursing looks like someone did not have the tools they needed and they came up with that.
Right. So why do you think we're doing that? Why are we inflating a tube into the esophagus?
Stop blood pressure.
To stop the blood flow, right? To compress it so that we don't have any more bleeding. Right, so that's how we're going to know that it's working, okay? Very good.
Is that person like, are they sedated? Are they awake during that?
Oh, no, they're out. Like, they have to have something to protect their airway, right? Because are they gonna be able to like do the things they need to do while you're putting this tube in? No, they need to be bound, right? And they're probably going to be out of it anyway with that amount of blood loss. Okay, so they need air. So always deflating the esophageal balloon before the gastric balloon, okay, because we don't want to include the airway in any way. Okay. Monitoring respiratory status, that is your #1 priority throughout, okay? The esophageal balloon will interfere with any of your secretion management, okay? So you may see more secretions and things like that, so we need to suction more frequently and protect that airway. Okay? And Lakemore or Minnesota tube are used interchangeably. So the video said Minnesota, but it's used here. Okay. Do you think normal bedside nurse, you're gonna be putting one of these bad boys in? No, probably not. Your rapid response nurse might be doing that, right? It's going to require some further training. But what do you need to know as a bedside nurse, like to do during this, when this is happening? What do you think you're gonna be doing? Monitoring the patient, monitoring your airway, right? Giving a history to your physician if they haven't met this patient. Right, those are your kind of primary things you're going to be doing. Okay. Splenomegaly, this is where the blood is shunted to that splenic vein. We saw that animation and how that kind of works. And we're going to have more blood cell destruction, right? So our red blood cells, our white blood cells within, production in the spleen. Okay, low platelet counts. We already have bleeding problems. Why not add some platelet problems in there, right? The TPA. You're gonna see this with these patients, right? Bleeding from weird places, maybe, like a nosebleed after they sneezed, right? Or spider angiomas. Has anyone seen these before? Like on the abdomen? from the nose. So it's like that spider webbing of, the vessels, is what it looks like. Okay. And then it says see tips procedure on the previous video as well. Hepatic encephalopathy, we touched on this, but again, that's the accumulation of those neurotoxins in the blood and increased cerebral edema risk, okay? Ammonia in the blood is no longer converted to urea and excreted, it stays in the blood. Okay? Again, ammonia in the blood does bad things for our brain function. Okay? So how do we get rid of ammonia in the blood? What medication? Lactulose. Okay, is anyone given lactulose?
Yes.
Okay, what does lactulose make you do? What? Diarrhea. Okay, because, and this is why, you need to know why. When you take lactulose, okay, that medication draws the ammonia from the blood, and the way it gets rid of that ammonia is through the stool. Okay, so think about like your KX late enemas for potassium, right? What's that? In the pulls into the large intestine, exactly. So, but when you start giving lactulose, you see a drastic improvement in mental status. Okay, very important that they stay with it. Do you think patients like to take lactulose? They absolutely do not, right? It interferes with their daily function.
When they see the
It's
cup,
gross too.
And
they're
it's,
like,
yeah, it's gross, and it's oral, right?
Yeah.
It's not a pill, it's
It's
just, it's a
liquid.
drink, right? Okay. I've had patients, they take a little sip of it and they're like, I'm done, keep going. Gotta take it all, right? Astigmatism, I always say it wrong, it's that liver flapping tremor, so of the wrist, hand, okay? Better hepaticus, has anyone smelled this before? Okay, the breath, someone with end-stage cirrhosis, it's like a fruity, musty smell. Some people say it smells like garlic sometimes too, but better hepaticus is that smell of the breath when someone has liver disease, okay, end stage. So you may actually see this on your boards or something to that effect. So if better hepaticus is an option somewhere, make sure you're choosing it, okay, for your liver patients. Personality mentation changes, you'll see that as well, and increased intracranial pressure because of what? Accumulation of those neurotoxins, right? So maybe ammonia is part of that, right? But accumulation of those neurotoxins lead to that cerebral edema, and then we need to monitor their intracranial pressure. Okay. Medications, we talked about this. Lactulose converts ammonia to ammonium iron and excreted through the feces. Rifaximin is an antibiotic. Neomycin, okay, reduces the bacteria that formed within, reduces ammonia forming bacteria because sometimes if you get a bacterial infection, they release more ammonia, and who wants that when you already have an ammonia problem, right? Makes everything much worse. Metronidazole, that's your antibiotic for the gram-negative bacteria, okay? So we need to make sure that we're taking care of all these pieces. Okay. Let's keep going for time's sake, but there are some examples here. So if you've never seen those hand movements and wrist movements with the sticks, I'm not gonna go for it. It's listed there for you, so you can see examples of that. Hepatorenal syndrome, that's when we talk about renal failure associated with cirrhosis. So this one, we're going to see excess nitrogen, sodium retention, oliguria, and hypotension. Why oliguria? What system's being affected? Not only the liver, but the kidneys, right? So your kidneys, if they're not getting what they want, or if there's stress to the kidneys, they start to shut down, right? That's why it's so important to monitor our kidney function with our urine output. And hypotension. Okay. The spontaneous bacterial peritonitis we mentioned, so that's again that inflammatory response with cirrhosis and ascites, increased abdominal pain leads to bacteria buildup, ascites, worsening encephalopathy. Okay, because again, some of those bacteria may release ammonia and cause worsening encephalopathy because we have ammonia. Okay, is everyone following me? We're starting to get some repetition here. You're understanding things a little bit better. Okay, diagnostics, liver function. Okay, total bilirubin level, CBC and platelets, because what other organs being affected? Spleen, yes, thank you. Coagulation studies, because your liver is very responsible for your clotting factors, right? Albumin, ammonia, okay. BMP, metabolic panel, ultrasound, liver biopsy, again, that's your most definitive diagnostic for cirrhosis, and possibly an endoscopy. What do you have to worry about with an endoscopy for a cirrhosis patient? Varices, right? We don't want to rupture those. They're dangerous. Good. Nursing interventions, monitoring that neurostatus. Again, if they get a buildup of ammonia, you're going to notice those effects pretty quickly. Okay, they may need some lactulose. Restriction of sodium. We want those kidneys to continue functioning, right? We don't want to end up with our hepatorenal syndrome. Restricting fluids, possibly, right? Because we don't want that fluid buildup and pressure. Because the fluid's going to shift to where? And follow the abdomen buildup, right? So we're going to continue to fill with ascites. So possible fluid restriction, providing adequate calories and protein. Okay, there's a little bit of a restriction to your red meats. Daily weights for fluid status, abdominal girth for ascites. Vitamins, thiamine, folate, and B12. Okay, we need those vitamins. Okay. These vitamins also help protect our nervous system status, right? Because we need those functioning vitamins and things to make sure that our mental status is where it needs to be. Okay. Which we're going to talk about that later. Absolutely no alcohol. Okay. I don't want you to drink alcohol at a family function. You need to avoid it at all costs, right? Because that's going to make your symptoms worse. Okay. Avoiding hepatotoxic drugs. What's a big one we've talked about? Did we say it? I'm sorry. Tylenol?
Yeah.
Yes. Okay. Acetaminophen. Preventing hypovolemia. Okay. So we may need to restrict fluids a little bit, but we need to take in enough fluids that we're not hypovolemic as well. And we need to make sure that all those fluids are not shifting to where they're not going to be. Monitoring for bleeding, implementing bleeding precautions. Right? Making sure we're protecting their safety, fall risk, because if they fall and they hit their head, there's a good chance they're going to have a brain bleed. Okay. GI bleeding also does increase your ammonia levels. They found that. And then preventing skin breakdown. Okay. Jaundice causes bile salt on the skin, and that's why they get really itchy. Those bile salts. Intense itching and also edema. So when your skin stretches, okay, has anyone had kids and your stomach itches really bad or anything like that? Stretch marks, think about those things. Intense itching overall. Let's do a practice question. Nurse is admitting a client who has hepatitis B with ascites. Which of the following actions should be included in the plan of care? Spell it out if you've got it. So, B, providing high calorie, high carbs diet. A, Hep B is transmitted via blood. Standard precautions are adequate. Okay, you don't have to implement contact precautions because what do contact precautions entail? Gowning, right? All of those things. Do you do that on behavioral health if your patient has hepatitis B? No, that's okay. You can use standard precautions. Daily weights, not weekly weights, right? We need to monitor this closely. Okay. And then C, largest part of the abdomen. Okay. So it's not necessarily you're measuring at a specific part, but you need to see how the largest part, okay, when they're laying flat. Okay. This one, a nurse is assessing a client with advanced cirrhosis. The nurse should identify which finding as indicators of hepatic encephalopathy. Select all. That's a scheme. Sounds like one. Okay, select all. So B, C, and E are correct. So B, change in orientation. Stick to the wrists, right? We talked about that one. And E, that are hepaticus. Okay. Hepatic encephalopathy. Just because someone has ascites, are they going to have issues with mentation? Not necessarily. They're more at risk, but that's not directly related. Okay. Because if they don't have a buildup of ammonia and things like that, okay, they may not have hepatic encephalopathy. Okay. And anorexia, you may see that in the liver dysfunction, but it's not a direct indicator of a hepatic encephalopathy. Does that make sense to everybody? Nurses caring for a patient with newly diagnosed hepatitis C, which of the following lab findings should the nurse expect? You may have to go back to that PowerPoint here. Findings.
Did it have the levels listed?
What's that?
Did it have the levels listed there, didn't it?
No, you'll have to look in your book. So this one is actually listed earlier, but it's actually B, okay? Your IgG, that's the one we're looking for in hepatitis A. And then in this slide, your AST and your ALT are both within normal. So you do need to look at those levels when you're looking for your. Okay. I think this is my last one. Nurses caring for a patient against cirrhosis. So the big thing you gotta look for hepatic questions is what part of hepatic tissues are we talking about? Are we talking about cirrhosis? Are we talking about hepatic encephalopathy? Are we talking about varices? What part of the process are we talking? Are we talking about hepatitis? Which of the following medications would you expect to be administered? Diuretics could be helpful to some of these patients. Yes, because of what process? That. The ascites, right? It's to help with that fluid. Beta blockers, what does that help with? Portal hypertension, yes. Do we want to give them acetaminophen? No, absolutely not. Lactulose, could that be helpful to them? Absolutely. And antibiotics. Yes, right, because we have to worry about those bacteria causing more ammonia buildup. Good. Substance abuse. So we're switching over. Substance abuse pairs really, really well with the liver. Okay, so we're going to talk about it today. This actually shifts over to your mental health book though. So the first portion was for your med surg book. This one's mental health. Okay, everybody following me there? So any references from this point on are from chapter 19 of your mental health book. Okay. So what is addiction? And we're going to talk about this a lot when Dr. Blocken comes in, right? That's a great resource for you, but we're also going to talk about it today. Addiction is a national health problem. There are more than 16.6 million adults, okay, living with addiction, and 697,000 adolescents from 12 to 17. That's with alcohol use disorder by itself. Okay, that is a lot if you really think about it. Okay, 3 million deaths annually. Okay. From alcohol use alone. So that's just alcohol. And how many people do more than alcohol, right? Or they don't even touch alcohol, but they're doing other types of substances, right? So addiction is a huge problem. Polysubstance abuse. So this could be legal or illegal. Okay. How are substances legal? Someone prescribes them, right? And they become addicted to those substances. Right? Or they're starting to use them in a way they weren't intended for. Okay. Illegal use, buying things off the street, right? You don't necessarily know what you're getting, but you're buying it from someone illegally. So polysubstance includes alcohol, ETOH, or prescription drugs. Okay. And again, it's abuse if you're using that drug in a way that it was not prescribed.
TOH.
Alcohol.
Okay.
Yep, it's just easier to type.
Okay, I got it. now.
Yep. Terms I need you to know: intoxication, overdose, withdrawal, and detox, and we're gonna dive into those more. Okay. Also, understand abuse is different than dependence on the drug. Okay? But abuse and dependence don't change how we're treating the withdrawal process or the detox process, right? It's gonna be pretty standardized across the board. It doesn't matter what the problem is or why, we're gonna treat everyone the way they should be treated for these things. Okay. Let's talk about alcohol first. So alcohol, there is a genetic link. Okay, so if your parents, abuse alcohol, there's a good chance that if you start drinking alcohol, that you could have some of those same problems, right? And it's also linked with social factors. Okay. So society or environmental factors. Okay. The average age for the initial alcohol intoxication is adolescence. Okay. I don't think that's very surprising. You might think that's surprising, but I don't necessarily think that's very surprising. Okay. If a patient has a blackout episode with no conscious awareness of their behavior and memory impairment, that's when we start to get a little bit concerned for our patients, right? A little bit. Okay. So know the terming for blackout episode, what that means. Tolerance is needing more and more alcohol for the same effect. Okay. Has anyone seen this before? Friends, family? Okay, so you need more and more. Okay. Tolerance break. So this can happen where small amounts of alcohol can actually intoxicate a person again. Okay, so they may go and buy, their standard 12 pack that it takes for them to get those effects. And then all of a sudden after 6, they're like intoxicated. Okay. Doesn't happen super often, but it can happen. Spontaneous remission. This is someone that says, I know I have a problem. I'm going to do something about it. Okay. And they take a break from alcohol and they have natural recovery process. Do you think this is easy to do? No. Okay. Very difficult. Because a lot of times if someone's, having alcohol withdrawal, what do they need to do? Do they need medical help to do that typically? Yes. Okay. Alcohol withdrawal can be very life-threatening. Earlier onset of use. So the earlier you start to use alcohol, it's linked to more poor outcomes with alcoholism. Okay. So if you started drinking regularly in your teens and continued that on, you are going to have, more poor health outcomes than someone who started later in life typically. Does that make sense to everybody?
I was shocked by the text of what it said about sipping. Like, oh my, that's,
Yeah, and I think I actually mentioned that here. Check. But your textbook really dives into all these different things associated with use. I'll never forget, I had a patient on a C-walk, and he was very, talkative about what was going on, and he had a lot of insight into his condition, and he told me he was like, I think I really realized that I had a problem when I couldn't stop thinking about getting off of work to go buy my alcohol. That was the highlight of his day. Okay, he was like, I didn't care about seeing my family. I didn't care about seeing my kids. I only cared about seeing that gas station show up on my way. And that's very sad. And I know for a fact that patient, he would not have been able to do it without medication, or it would have been a very serious condition. Because, we're going to talk about how soon you see symptoms after stopping your drinking. And the sooner you start to have symptoms of withdrawal, the more serious. So couldn't even get through half of his workday without thinking about it or something over it. Okay. Alcohol intoxication and overdose. Okay, so there's a box in your book, the physiological effects of long-term alcohol use. And here's where I break it down: intoxication versus overdose, because they're different. Okay. Intoxication, this is milder symptoms. Okay. These are, people going out to bar to have a good time, right? and their speech is slurred, they might be a little bit unsteady in their gait. Lack of coordination, okay. Some people will say alcohol brings out the worst in me, right? So aggression, also in your intoxicated states, concentration and judgment issues. Okay, so think about your typical person you see who's intoxicated, okay? Overdose is more serious and urgent, okay? So this comes with vomiting, respiratory depression, risk of aspiration because of vomiting, okay? Leading to possible shock and death. These patients need to be seen, they may need gastric lavage, or in very serious cases, dialysis to get rid of those toxins from the body. Okay.
Is that a one-time dialysis normally, or would that be given?
Not typically. Okay.
So,
No, unless, you know, they lead into other systems that are being affected or long-term complications. But it's just to initially remove that from the body. Okay. So probably everyone who's seen someone intoxicated, overdose is a little less common, but it starts with that vomiting, right? Our body's telling us to stop. Right? Somebody's not there. You have to not. The alcohol withdrawal, the CWAS scale, so I do need you to look at this in your book. Okay, I need you to look at the scale and understand why we're doing it. Okay. And the importance of it. So alcohol withdrawal can start anywhere from 4 to 12 hours after you stop drinking, okay, or decrease your intake. Okay, so some people, you know, they go to bed and they wake up and they are in alcohol withdrawal immediately. Okay. Signs and symptoms, they're gonna start to have some hand tremors, sweating, elevated pulse and blood pressure. Okay, with your CWAS scale, can you do a CWA without taking a pulse and blood pressure? Nope, you can't because that factors in. Okay. If your withdrawal is more severe, it's going to lead to hallucinations, seizures, delirium or DTs, delirium tremens. That's life-threatening. Okay. I'll never forget, as a PSA, you know, I was very new to healthcare, and I go in to sit with a patient. I'm like, this is perfect. She's sleeping. I was like, this is going to be the best day of my life working. She woke up and I'm telling you what, she was seeing things all around the room. She was attacking me. I wanted to go home. I was terrified. This little lady like was coming after me. And I didn't have much of a report. They were just like, oh yeah, she's gonna sleep it off. Like she's gonna sleep all day. I was like, great. Nope, she certainly did not. Okay. She was hallucinating that I was attacked, you know, things were attacking her. It was a very scary situation. But needless to say, she got some medication at her next CWAS score, right? So that's how that all plays it together. Alcohol withdrawal peaks day 2 up into about 5 days. So this is typically when these patients are being managed, right? In the hospital. Okay, but the effects of withdrawal can last up to 1 to 2 weeks. Okay, so I always tell my patients, you're not going to be feeling good for a little bit of time, right? Or let's say behavioral health. These patients don't stay for weeks on end, do they? No. So you have to educate them when they leave. Like you're still going to be going through some withdrawal symptoms. You need to, you know, take it easy. The worst of it is over, but you need to continue this if you don't want to end up staying ignored, right? With the DTs are life-threatening, like I said, they need, and alcohol withdrawal in itself needs supervision. Yeah, they should be, you know, being managed in either an outpatient recovery setting, maybe coming in frequently, or in the hospital. Okay. Mild symptoms of withdrawal, you can typically treat it. Okay. So how are we going to treat this? Your book lists everything out, but benzos are great for this. Okay. Lorazepam, or diazepoxide and diazepam. Okay. You're going to always, pretty much wherever you are, see some type of tapered dosing system. Okay. It's going to be based on how high they score on your CWA-AR scoring gun. Okay. So that's why I said you need to know what your scoring system is and look at that in your book so you know what kind of medications and taper. So if they score higher, Do you think they're gonna need a higher dose of the medications? Yes. Okay. Substance abuse treatment. So again, drugs are all listed in your book and we'll talk about some of those. But there are specific drugs that we use for different substances. It does depend on which substance we're talking. Okay, so if it's a stimulant, we treat that differently than a depressant, right, into your nervous system. Okay, and we need to tailor the dosage based on the patient needs, because again, these patients have been drinking or doing these substances for different amount of time, so we need to treat them accordingly. The goals is a safe withdrawal process and preventing relapse. Again, so this is why education is important. Okay? We don't want you to go home and take one drink and say, "Oh, it'll be fine, I'll take one drink." Right? You're gonna throw yourself into it. Okay. So CNS depressants. So if someone is on barbiturates or benzos, those are CNS depressants, right? We're getting through mental health pretty quickly. Has pretty much everyone seen in report what kind of substances people are on, and sometimes it's a whole lot of, right? Sometimes it'll say like marijuana, barbiturates, Suboxone, you know, opiates. They're listing everything that's possible. Okay, sometimes it's just one or another. But with depressants, you're typically going to start to see things like slurred speech and coordination. Okay, maybe low blood pressure while they're on the substance, impaired judgment. Okay, so what are those symptoms similar to? Intoxication with alcohol, right? So does it make sense that we treat alcohol withdrawal with benzos? Yeah, right, because it's gonna mimic some of the effects to the central nervous system, and that's why they work. Okay. Overdose severity, so benzos. Rarely are those fatal overdoses, okay? Barbiturates though are lethal. Okay, so if you overdose on a barbiturate, it leads to things like coma, respiratory arrest, cardiac failure, or death. Okay. Withdrawal, so symptoms are based kind of on whatever the drug is that they're taking, half-life. Okay. The big thing with overdose, maintaining airway, vomiting, so to get that out of the system. And I need you to remember this, okay? Benzos, you administer this with Mazinel. Okay, you have to know this for your boards. Okay, same as your heparin and what? Protamine sulfate, you just have to know it. Okay. Tapering, we have to do this with barbiturates, especially to prevent coma or death. Okay, benzos, we should probably be tapering as well, because they're gonna feel pretty bad. We just abruptly stop those benzos. Okay. Has anyone seen anyone who, especially when I feel like lorazepam or Ativan, when it first came out, they kind of prescribed it like candy, right? And then they needed more and more to get things that's very similar to your alcohol. So we need to try to taper them down because their body is so used to it, right? And that's why it's not prescribed as much anymore. Outpatient. Right, it's like we learned our lesson.
You actually get a withdrawal from them to.
What's that?
There's a withdrawal from them.
Yes,
Those medications.
yes, absolutely.
That will start on.
Yeah, and it's not to say like, just because something's not immediately life-threatening to withdraw from, doesn't mean that it's not terrible, right? So there are treatment centers and things like that. And even in behavioral health, we have a lot of patients who may take benzos or things like that. And we give them, you know, small tapered doses to help ease that effect, right? Stimulants, okay, so thinking about our cocaine, amphetamines, like your methamphetamine, right? Symptoms of intoxication, rapid onset, okay? Euphoria, aggression, elevated BP. Stimulants, think up, right? Tachycardia, dilated pupils. Okay. They may also have nausea, chest pain, or dysrhythmias associated with. If they overdose on these things, myocardial infarction, stroke, coma, and death. Okay. Cocaine. So has anyone ever heard of, you take cocaine, you're gonna end up with a stroke at some point in your life, right? It causes vessel occlusion, so your vessels become very occluded over time, and constriction of the vessels, so you may end up with like those TIA attacks, transient ischemic attacks, or a stroke later in life. Crazy story. I'll just break. So we had a patient, actually an OB, and you're gonna see why this relates in just a second. And it's a wild story. So she came in and she was having a placental abruption. So basically, all the vessels of her placenta constricted so much her placenta detached while her baby was still inside. Okay, you have to have the placental exchange to be able to have, you know, your baby getting all the nutrients and oxygen that it needs to survive. Okay, so she came in with a placental abruption. Baby was still okay because there was enough of the placenta that baby was still getting what it needed. And we were trying to figure out why it happened. And we just couldn't figure out why it happened. We're talking about, do you do drugs? Do you do, you know, what do you do? Like, what could have possibly factored into this? Went through all the risk factors. And there was nothing. And then her boyfriend comes in and he's like, you think it could have been because of the butt stuff that we did? I'm not kidding. That's what he said. And we were like, what do you mean? So he actually rubbed cocaine on her anus. Okay, not kidding.
Keep going.
Not kidding. Okay, this is gonna help you remember this. And because you have so much vascular, you know, areas of your anus, it absorbed into her own system. Okay, and he said he did it to make it more comfortable. So he did that, right? And she said she had no idea it was happening. Okay. Ended up causing those vessels in her placenta to close off and her placenta to erupt. So, cocaine is not good during pregnancy. Could you imagine that? Okay. So you may hear this in 2023 if I don't, but I told you that. But that's one way to remember that cocaine is really bad for you, right? Because it causes those vessels to constrict so much that it could, you know, cause, think about vessels in your eyes, right? It can cause eye damage and things like that as well. But off of that subject, right? Withdrawal from stimulants is typically not going to be life-threatening, okay? However, these patients are not happy, right? Has anyone seen anyone withdrawing from like methamphetamine? It's not a fun time, okay? Thorazine can be given for any hallucinations that may occur during that time, blood pressure issues, or nausea, okay? Make sense to everybody? And then I'm gonna hit on, I think I can finish this before we take a break. So cannabis, most widely used illicit substance in the US. I don't think that's a shock to anybody. Short-term use does lower that interocular pressure. So has anyone heard of it being prescribed for glaucoma or taken for glaucoma? Right, Lil Wayne was like, I take it because I have glaucoma. Okay, sure. Studied for chemo-induced nausea and age-related weight loss. Okay, no antidote. It does support respiratory. We do need to support respiratory and cardiac functions. Okay, until the drug is done. So if they have high doses of cannabis, you need to make sure the respiratory status is intact and their cardiovascular status. Rape and club drugs. So we have ecstasy or MDMA. That one is a stimulant. Okay. Causes hallucinations. Okay. Risks: hyperthermia, heart attack, or heart or kidney failure, dehydration, and death. Okay, so these are not safe to take, right? Not a good time. Has anyone heard of, there was a festival a few years ago, I was actually working that night, and we had trauma after trauma after trauma coming in. These people at this festival near were taking drugs from people they didn't know, and they were coming in overdose. One after another after another. And it was some form of MDMA is what they found out. But yeah, and it was in the summertime, and this causes dehydration. So everybody was just passing out, right? Because they weren't drinking water. It was just a big problem. Okay. date and, date rape drugs, so that's your Rohypnol, GHB. So you do need to know this is very important. Effects are similar to benzodiazepines, but they cause amnesia. Okay, they cause short-term memory issues. Okay, and that is why people use these for sexual assault. Okay. So it's very important that we understand these these drugs and what they're doing.